Good morning and welcome to the Norfolk presentation to the Health Service Research Conference on the Self-Isolation Support Project. My name's Cindy Marsh, and along with my colleagues Suzanne Wilkin and Michael Cutter, we all work for Norfolk County Council in the Public Health Outbreak Management Centre. We're going to be talking about the outline of the project, and this will include the importance of self-isolation in public health and outbreak control, the aims and objectives of the project, how we try to understand the motivations and needs of local people who are required to self-isolate, and our behavioural intervention model that guides us in the project to do this. We'll look at the collaborative partnership approach, focusing on our existing networks, our resources and our assets, and we'll explain the information process to date and how that has informed the evaluation. And then we'll talk briefly about our intentions for the next period. Thank you. So in terms of self-isolation and the Norfolk Outbreak Control Plan, isolation as a cornerstone of control measures in public health has been around for centuries in the UK. The photo on the slide is the village well in Eyam, a village in Derbyshire, which in 1666 had an outbreak of bubonic plague, which was brought into the village within a bale of cloth being used to make clothes, and that bale of cloth was infested with fleas carrying the bacterium Yersinia pestis, which is the bacterium that causes bubonic plague, or the Black Death. And the villagers, there were about 800 people in the village, made the heroic decision at that time to self-isolate themselves from their surrounding communities to stop the transmission of the bubonic plague to Sheffield and the surrounding areas. Out of those 800 approximate villagers, 260 died all told at the end of the outbreak, but they self-isolated throughout that summer until November 1666, and as a result they prevented the onward transmission of bubonic plague. The well was used as a boundary marker and a designated site to deliver food, medicines and essential supplies, and they were left at the boundary of the village for them in order to complete their self-isolation, and they paid with coins that were kept in a bowl of vinegar to disinfect them. So the impact of this self-isolation controlled the virus 3.5 centuries ago, and now we have Test, Trace and Isolate as a programme which is emphasising the importance of self-isolation, and we have legislation that enforces self-isolation alongside sanctions for people who don't complete it, where fines can be administered of £1,000 and over. In the project today that we're talking about, the local opportunities and differences are that we are trying to empower and support people at a local community level to be able to meet their self-isolation requirements, with delivering local support, practical on the ground help in a variety of contexts. So the aims and the objectives of the project are the next slide, please. We aim to support the highest possible levels of adherence to COVID-19 self-isolation by providing practical, tailored local support. And over the last 6 months, we've worked in partnership across our existing areas and networks to offer that support at the earliest possible point within the self-isolation period of the individual case or contact. We've provided and facilitated support when requested, and we're evaluating the effect on self-isolation compliance. And Suze is going to talk a little bit now about the project delivery on the ground. Thanks, Suze.
Thank you. So all 7 of the districts in Norfolk deliver this service, and it operates over 7 days a week and including bank holidays because the pandemic doesn't stop during this time. They deliver it in both a mixture of doorstep visits and also phone calls as well, which gives flexibility in terms of the geographics and also the outreach of the service as well. The data that they receive can be enriched, and it operates on a priority system as well. So getting to people who are clinically extremely vulnerable, have already expressed the need for support, and also those that are early on in their isolation period, so that the COVID marshals who deliver the service on the ground can actually reinforce those different public health messages. And of course, getting that support to them and offering different signposting opportunities as well, both locally and also nationally. And this service as well already had a very strong support network already in place. Thank you. So people's adherence to self-isolation is often complex in terms of the barriers that they can face. And some research has shown that early on self-isolation adherence was quite low. So we wanted to explore some of the reasons why people would break their isolation. So our experiences in Outbreak Management Centre and also the feedback from the districts enabled us to pick out some of those barriers. So for example, people breaking their isolation through taking their dog out for a walk, or actually holding their own services at home, for example, a child minding service. So the service aimed to clarify the guidelines and rules around self-isolation and reinforce those, and also to be able to offer a more person-centred approach as well. So being able to, for example, cater to different religious needs and also dietary needs as well when offering support with food parcels and food collection. So, for example, taking into account vegetarian and halal needs as well. The service aims to be flexible and also to help people to think outside of the box as well with their support networks. So rather than giving people support straight away, but in terms of thinking about, you know, what support is already available to them, maybe through social networks, and also looking at more local and also national support that we can offer them as well. And we aim to obviously get this support to people at the closest opportunity. Thank you. So we wanted the service to be a behavioural intervention and support rather than a policing. So we looked at, again, the sort of complexities and barriers that people face and embraced the COMBI model to help to match those needs to the support that we offer. So thinking about capability, so helping people to understand how COVID spreads, the symptoms and what is self-isolation. Different opportunities, so if someone's struggling with paying bills, then linking in with our local financial support and also our national support as well, and the motives for helping people to stay self-isolated, so thinking about the impacts on their families, friends and also communities as well. We developed a bespoke self-isolation guide, which reinforced all of these public health messages, help people to understand the reasons behind it, and also linking, of course, to signposting and also that local and national support. And also made this guide available in different languages that are spoken across Norfolk and also in an easy read guide as well. Thank you. So the approach, of course, has got to be collaborative in order for the service to run effectively, and the districts were well set up to be able to provide bespoke support and communication, and often the COVID officers are multi-skilled with experience of vaccinations and also the marshalling they do around the communities as well. Thank you.
Thanks, Suze. So now let's take a look at some of the qualitative measures of what the service does and who it helps. So since it began in around January this year, over 10,800 contacts have been attempted, either over the phone or through physical door knocks by someone from one of Norfolk's 7 local district teams where support needs are discussed face to face. We've successfully reached the contact in 91% of those attempts and have a really high 99% of individuals self-reporting compliance to the isolation guidelines. We've had 398 contacts who've requested isolation support from us so far, and that's where we'll focus on today. So when has the service been used the most? Well, isolation support requests have occurred very much in line with cases during the second wave, as you can see in the bottom left-hand chart. And on the right-hand side, we can see the different demographics of those who have requested our support. Most frequently, we've seen women between the ages of 30 and 49 requesting support from this service. Next slide, please, Hannah. So now let's take a look at what kinds of vital support the service has provided. On the left, we can see how these different support types have made up more or less of our total support requests since the service began. Financial help was most commonly requested during the peak of the second wave, while as case rates have fallen more recently, food-related support has taken up a larger proportion of our support requests. On the right, we can see which forms of support are most commonly requested and how these differ based on which method individuals are contacted by. Support related to food and finances are requested most often, followed by medicine collection, dog walking, and then other specific requests. One key point worth further investigation is the difference in financial support requests over the phone compared to a physical front door visit. Our goal is to ensure people get the support they need early on to complete their full isolation period and prevent further spread of the virus, but also to offer more general support to those who need it outside of self-isolation, looking to the longer-term health and well-being needs of the local Norfolk population. Findings like these may help us uncover and overcome stigmas surrounding certain types of support and ultimately offer more support to people both over the phone and in person. Thanks, Anna.
Thank you. And although the pandemic has brought a lot of sorrow to thousands of people, the service has enabled us to provide support to people that may never have needed support before, and has also opened the door to help people to realise how many different services their local council actually provides and support that comes with that as well. And it's clear in a lot of this feedback as well that the intervention and support that the COVID marshals have offered to people have helped them to adhere to their self-isolation. Thank you.
And so in relation to our next steps, at the time of recording this presentation in early June 2021, we are cautiously waiting to hear on the decision to be made about easing the final stage in the government's roadmap for lifting lockdown restrictions and the impact that that will have on the project and our wider outbreak control management work. In Norfolk, we remain at the centre of a national public health response within the context of a global COVID-19 pandemic. And from the evaluation we've conducted on the project to date, building sustainable local approaches, it's becoming clear that locally embedded, locally tailored, rapidly delivered support on the ground can improve compliance to self-isolation and halt onward transmission, suppressing the COVID-19 virus to the lowest possible incidence rate. Thank you. So at this point, I would just like to thank you for listening and also to take the opportunity to thank all of the networks and the communities, the partners and the stakeholders who have been involved with the project so far over this period. And we welcome your questions about the project, so please do get in touch. Thank you.